you, Junaid. Thank you, Dr. Levent, for the introduction. And, the situation in elderly patients is totally different. We are not expecting to have symptoms different from those that we know that exist in lower urinary tract in lower urinary tract voiding, storage, and post-voiding symptoms. And from the EPILOT study that recruited patients above the age of 40, we see that the clusters that were identified in terms of lower urinary tract symptoms are not different from younger and older patients. What we see is that the older patients will have more severe and more bothersome symptoms. And this is also confirmed by studies carried out in different countries. Each bar is a country, and what is shown here is the change in IPSS score in patients that at baseline had an IPSS score above 7. So there is a gradual increase in the total IPSS score as age increases, and the variations between countries should probably be attributed to cultural backgrounds. So which are the main causes of lower urinary tract symptoms in aging males? And they are indicated in red: benign prostatic obstruction, detrusor underactivity, overactive bladder, and nocturnal polyuria. Of course, one can imagine that these patients might have bladder tumors, might have neurogenic problems, might have urinary tract infections, but let's ignore this part because I only have 10 minutes, and we'll start by benign prostatic hyperplasia, which increases with age. And from the Olmsted county shown on the top right, there is a gradual enlargement of the prostate gland. So we have BPH, we have benign prostatic enlargement, and then we have benign prostatic obstruction, which might affect the bladder function. Also in different ways. Bladder outlet obstruction might cause complications. We know that, of course, these are not exactly lower urinary tract symptoms, but patients might complain of acute urinary retention, of hematuria, of symptoms related with bladder stones or bladder diverticuli, and we cannot ignore that some of these patients might have renal insufficiency, so they might have symptoms related with renal failure. By the way, by the age of 70, the cumulative risk of acute urinary retention, according to the Olmsted County, is about 9%. So, which is already a very high rate. The other cause for lower urinary tract symptoms in elderly patients is underactive bladder. And a few years ago, diabetes was clearly the main cause. The diabetic cystopathy. But nowadays that we are achieving higher ages, clearly bladder outlet obstruction is an important cause of underactive bladder and may affect both the myogenic mechanism, so the detrusor, the parasympathetic innervation, and the sensory innervation. And in addition, some of these patients might have neurological problems that contribute to the underactive bladder. Here I make a summary of the mechanisms that might cause underactive bladder in patients with BPH. One, of course, is related with the changes in the detrusor. So after a compensatory hypertrophy, due to ischemia, perfusion ischemia, the detrusor might suffer an accumulation of collagen, and the smooth muscle cells might suffer atrophy, so the decompensation phase. Also, we know that the cholinergic innervation is lost. Bob Levine showed that the enzyme that produces acetylcholine, the choline acetyltransferase, is decreased after obstruction. We know that ATP that initiates the sensory activity is decreased in the detrusor overactivity caused by bladder outlet obstruction. And we know that there is an urethral bladder reflex, and this urethral bladder reflex is dependent on serotoninergic cells in the proximal urethra, and with aging, the number of serotoninergic cells is decreased, and so this reflex is lost or impaired. Which are the main symptoms of patients with underactive bladder? Well, this study compares the symptoms of patients that in pressure flow study had the detrusor underactivity compared with patients that had a normal pressure flow study. And clearly, the voiding symptoms are predominant. Weak stream, interrupted stream, hesitancy, straining to void, although some decrease in the sensation of bladder filling and incomplete emptying were also present. But storage symptoms are also important in this group of patients. This is a study from Michael Chancellor, so it's a survey, and he sent the questionnaire asking patients if they had straining, difficulty in emptying, or if they had episodes of urinary retention as markers of the detrusor underactivity. And if the patients had, for example, 2 or 3 of these, would respond yes to 2 or 3 of these 3 questions, you can see by the red and the green bars that the percentage of patients with storage symptoms, nocturia, urgency, and frequency is very high. So in patients with the detrusor underactivity, storage symptoms might also be important, or are important, is better. What about nocturia? It increases with age, whatever the number of episodes of nocturia we have, 1, 2, or 3, it doesn't matter, it increases with age. And one of the main reasons for this increase is nocturnal polyuria. And this is a good example. This is the SIRE study, which included patients with benign prostatic enlargement above the age of 60, and all the patients had to fill a frequency volume chart. And 30% of them had nocturnal polyuria. And so in these patients with nocturia, elderly patients, or a significant part of them have nocturnal polyuria, and that must be considered when we want to treat these patients. Then we have OAB, increases with age, and by the age of 70, as you can see on the right side, OAB symptoms, the prevalence will probably be slightly higher than in women. So we expect to have urgency, to have nocturia, to have frequency, and to have urgency incontinence. Of course, if we consider these symptoms isolated, there are differences between men and women. Men tend to have more OAB dry, and although urgency urinary incontinence increases with age, as you can see in the Noble study in the lower graphic, it never reaches the same levels as women. To finish, we have to remember that elderly patients might have demential problems. Alzheimer's disease is certainly more common in women, but still it might occur in men, and particularly in men above the age of 70. And looking into the graphic on the bottom, you see that as time goes by, the incidence or the prevalence of incontinence in patients with Alzheimer's disease increases. And this is a difficult symptom to treat when associated with cognitive problems. Moreover, some of these patients might have as treatment cholinesterase inhibitors, and these drugs, at least in the very beginning of the treatment, might increase the acetylcholine available in the bladder and might in fact increase lower urinary tract symptoms, particularly urgency incontinence. So in conclusion, Mr. Chairman, dear colleagues, LUTs in elderly males are the same as we can see in younger subjects, but the prevalence and the intensity in the bladder is probably higher, is certainly higher than in younger patients. The main causes are bladder outlet obstruction due to benign prostatic enlargement, underactive bladder, OAB, and nocturnal polyuria, and we must consider also dementia, and the management should be initiated only after a careful investigation in order to establish the causes of these symptoms. Thank you very much.
Mr. Cruz'a bu güzel konuşması için çok teşekkür ediyoruz. Şimdi tabii akışı çok bozmamak adına bir soru varsa podyumdan alacağız. Bu arada görevli arkadaşlardan bir sonraki tartışma için koltuklar gelecekse alabilirsek bu arada. Evet, soru var mı?
Çok teşekkür ediyoruz. Çok güzel bir sunumdu. Her zaman olduğu gibi. Sizden daha önce de az çalışan mesaneyi dinlemiştik ve çok da önemli bilgiler almıştık gerçekten. Ben bir şey soracağım. Bu hem benim prostat büyümesi olan hem de az çalışan mesanesi olan yaklaşık 60-65 yaşında bir erkekte transüretral rezeksiyonun yeri var mıdır? Yoksa bu hastalara zaten işleyemeyeceği için, mesane çalışmadığı için bu ameliyatları yapmamak mı gerekir? Siz daha önceki sunumunuzda geçen senelerde bunu çok güzel anlatmıştınız. Bir kez daha vurgular mısınız?
Okay, with pleasure. Of course, if we have underactive bladder and bladder outlet obstruction, we might try surgery, but we have to inform the patients that the results might not be ideal. What type of surgery should we use? Of course, it depends on the size of the prostate, but clearly what is shown is that the enucleation is the best form of surgery because it's the one that is going to reduce most the obstruction caused by the prostate enlargement. But of course, that depends on the size of the prostate. Anyway, we should expect that only 70% of the patients will start to void it spontaneously, and 30% will remain with some kind of high post-void residuals and will require some form of clean intermittent catheterization to empty the bladder. There is no other treatment, unfortunately.
Çok teşekkür ediyoruz. Sağ olun efendim.
Thank you.